Hey, how are you?
Good.
You look a little shiny today.
I just put a thick layer of moisturizer on my face.
Uh-huh. Can you towel off before we start?
No, because
No?
it's supposed to, how is it going to hydrate if I take it off my skin?
Can't you delay hydrating until after the
Is
podcast?
it distracting?
I just think the guests may see the reflection off your skin and be blinded. That's what I'm concerned about.
Um,
There's a lot of glow
it
coming
is a
at
little
me.
more than I intended for a public audience.
If you want to get like a wipe or something,
Yeah.
feel free.
No paper towel.
There you go.
Thanks for keeping me in check
You're welcome.
for the people. I'm looking over my notes for Dr. Baird. I went to an Invisalign course in Arizona, all for residents, and she was one of the main speakers. And she did like a private tutorial, and she would answer questions and go through cases. She's like Invisalign's shiny star student. She's, cranking out Invisalign cases. So I'm excited to selfishly have like a tutoring session.
So the first half we're going to talk about her career.
Yeah, I want to get a sense of imagine if in law, all of a sudden, this whole new way of practicing law came about that you were supposed to enforce if you wanted to keep up with like the young hip clients. And you, as a practiced lawyer, had a way of doing things and everything was working just right. And now all of a sudden you have to like dive into something. And I'm sure there were a lot of skeptics back then, like, is this kind of for real? You know what I mean? So I'm curious how she got to be where she is today.
Like at 6:30, are you going to pivot into reviewing case studies with her? Is that how you see this playing out? Like what
Yes, we'll start doing that and we'll
do you
switch
want me
to.
to stay on at that point? I
You
mean,
don't have to. I mean, if you're interested and you just want to get a sense of what it is that we do, I think you could be interested for like
can I
five
can I
minutes.
like decide midstream to drop?
Yes, no one's going to even notice.
And then how do I drop? I hit
Hmm.
leave at the lower right corner, right? Okay. I know how
Yeah,
to do it.
and
Yeah.
yeah, you got it.
Okay. I mean, if it's really dull, I'm probably gonna
Yeah,
drop.
yeah, you can drop out whenever, but I do
Not
think.
not not dull for you people, but dull for non-professionals,
Right, I got that.
the patient population.
Yeah.
I guess that's
I
my
think what we
I
do is
represent.
really cool. So I think that everyone should just stay along for the ride just to see what goes into a treatment plan.
There's going to be a lot of saliva discussion as part of that. Is
No,
that
we're
yeah?
like the like clean sheet, cute
Uh-huh.
orthodontist type. We
Oh,
don't we don't deal with that kind of thing.
okay. So
No icky stuff.
no spitting,
No spitting,
no
some.
drooling,
Yeah, well, at least
no
not
dribbling,
virtually.
no dribbling. Yeah.
Yeah. I
All
do
right.
sometimes get the occasional saliva to the eye.
Oh God,
Um,
that's disgusting.
So today we have on Dr. Marta Baird. If you're in dental or ortho, you probably already know her. She's an icon with Invisalign. And I actually first met Dr. Baird at an Align conference, and I was just immediately drawn to her. She's so confident, thorough, knowledgeable, and she just explains things so clearly, especially for someone who's new to the material. So, Dr. Baird is a successful practice owner at Baird Orthodontics in the Bay Area and an Invisalign expert and consultant for Align. And she also teaches at the University of the Pacific. So, in this episode, we break it down into two parts. The first half is on her business acumen. So, we dive into the private practice experience and how she managed to achieve such a successful private practice in such a competitive market like the Bay Area. And then in the second half, it's all about clinical. So Dr. Baird shows us two complex cases, and my old co-resident, Michelle Skelton, and we ask her all the, dumb, raw questions about the clin check so you can learn exactly how an expert like her would be thinking through these types of treatments. So whether you're looking for how to improve your private practice or you just want to level up your clin check skills, this episode is for you. So let's welcome Dr. Marta Baird to Medical Morons.
My path to private practice was very quick. So I graduated in 2011 and the doors opened to my startup practice from scratch 2 years later, 2013 in August. This was a really intense first 2 years out. And I had this vision that I wanted an aligner only practice. And that was because I had aspired to mentors that I had met while I was in residency. And pretty quickly, the way the market was at the time, my community was not ready for that. And so just hemorrhaging money for the first 18 months, a total of 41 starts, and it's all lab bills. So pretty quickly realized I needed to get back to traditional brackets and wires, get on board with all the insurances. And then I was sort of in this sort of floating state where I was doing orthodontics the way I learned in residency, which was a little bit of a hodgepodge since we had so many influencers. And I realized I needed something. I need a mentor. Every time I reach this crossroads in practice where I need to streamline something, I was dabbling in indirect bonding, trying to be progressive, to make it so that my brackets and wires could be more efficient, like what I had learned with aligners. So I had already seen this mentor of Dr. Richard McLaughlin as a good example of someone who would have practice workflows, arch wire sequences. Everybody can be treated excellently at scale. And so that was always my vision of, I wish I had a practice like this, that it could be as good as what we learned in residency, but in a busy practice. So when I completed this, that's basically when I started teaching, like in general. So I was recruited by my university in 2016. As soon as I finished the McLaughlin course, let's get Marta on the faculty and teach the residents what she learned in San Diego from Dr. McLaughlin. So I was not recruited for teaching Invisalign at my university, even though now the residents come to me and ask, is it okay if I show you a braces case? Because they think I only do aligners. But it's always been a fortunate interaction with my university and with my mentors there that brought me into the fold for Align. As you may know, Dr. Robert Boyd was our chairman at that time. He was the first orthodontist using Invisalign, and a lot of the clinical studies were done at our school. So after teaching fixed appliances for a couple of years, he said, Marta, I'm retiring. I need you to make an Invisalign course for the residents. And that was right around the pandemic 2020, where we were closed. So I had these amazing 8 weeks of no patients where I was just focusing on learning everything I could about aligners. Every webinar that there was currently that you could listen to on the website. I went to, right before the pandemic closure, I'd gone to a workshop for Invisalign faculty, like people who teach clear aligners in universities. And it was that epiphany where I get it. I understand how we're moving teeth with this and how we can get these outcomes. Then having to teach it, so then I had to understand it better. And it was probably a year or two of that before I even did my very first lecture for orthodontists on behalf of Align as a consultant. So I had already been teaching aligners to the residents and to local study groups and things like that. And then it just took off from there. Pretty much did my first speaking engagement for them. And then 6 months later, I was speaking at the summit about how to do a 10-step clean check, which is what I taught the residents and developed with the residents. And then it's gone from there. So now I probably travel 3 weekends a month during the busy season lecturing for Align, but coming at it from the focus of like academics and education. Yeah, so
it's interesting to me. I've taught a little bit too. How much of your time do you spend in the clinic, and how much of your time do you spend teaching? And maybe talk a little bit about what it is about teaching, because obviously you must enjoy it a lot.
Basically, the first 2016, when I started teaching, was when I had gone from working as an associate at 3 locations plus having my practice. And I had just stopped working at the last associateship. And my chairwoman just called me and said, Marta, remember when you interviewed, you said that you would come back and teach during your interviews for residency. It's time. So it was a little bit of coercion at first, because what person that's only 5 years out thinks they have time to come and teach? And I would say probably the sooner you start, the easier it is to get into the teaching part of it. I think that if you spend too long out there, you start having a family, life just gets busy and it takes off. And so what I realized with working with the residents was I was getting that pressure to get better. They asked the challenging questions. I had to stay innovative. I had to look and reflect on my own cases and figure out what I did, what I could teach that went well or what didn't go well, which was a major focus for me. So it was in teaching that I got faster and better at clean check, understanding different side effects and all the little creative pieces. So for me, it's really exciting to see the residents' eyes light up, because it's a small group of 8. You can see their facial expressions. The one-on-one I really enjoy with the residents because I can see them grow. over the 27-month program.
And how much, I'm sorry,
Oh,
Kylie,
how
just
many hours, where am I spending my time? So
yeah.
private practice is 3 days a week, and
Hmm.
it will never grow past that because I would spend every Tuesday going on the train to to teach at the university. And now I spend a lot of Thursdays flying out. So I have an associate on Thursdays now. So the clinic is there 3 days a week, but yet it's grown in volume because of the whole digital workflow. And so I can always scale and add more patients into it. I just take advantage of all the digital tools. So 3 days a week practice, and then 1 day a week teaching. And apparently I work 8 days a week. So
And honestly, from what you've been saying, I feel like you need 8 days a week, so that's starting to add up. I mean, I have so many things I want to ask, but I guess when you started talking about your digital workflow, and I remember you saying at the Invisalign course for residents that we first were introduced to you in January, that I think you spend 2 minutes or less per clean check. Is
it's
this
more like five. It's
okay?
more like
Maybe you said five. Yeah.
five to eight if I'm explaining it to someone. Like typically eight if I'm having to explain everything that I'm doing, but if I'm just on my own, it's probably about 5 minutes. And then it's got to come back to me after that initial workup because I'm experimenting with different custom staging that is not in my IPP. So I'll do the whole workup, get the final positioning, get the over treatments, get the attachments, and then send it to the CAD designer. Then when it comes back, that's like another 30 seconds or so.
So I'm just even fascinated that you're keeping track of these times because I'm so focused on completing the clin check that I can't imagine timing myself. I would feel like I'm like taking the SATs or something. So can you talk a little bit about how you developed a digital workflow? How was that just trial and error? Did you again just follow webinars and kind of learn from your mentors? Because like you're describing, you have it down to a science. So I want to get a bit of an understanding of that.
I guess the way that my mind works whenever I'm doing something, I start multiplying it. So if it takes 30 seconds for a clin check from clicking it for it to open up on my screen, and then I have this many starts a month, and I have this many refinements, and I have this many modifications for each one, I start multiplying and I start emailing a line saying, you've got to make this faster, right? Because the minutes start adding up. So I've always had that tendency to start counting my minutes. I think all orthodontists are a little bit like looking at their watch, every
Yeah.
time somewhere.
It's a
So
strange breed for sure.
we're second counters, right?
Yes, yes.
And so it was always this realization that time is limited and I want to do more. How can I do it more efficiently? Or I'd run into a bump. It's always a bump in the practice. Something didn't go as we expected, whether it's patient satisfaction, whatever it is. And then it's back to, okay, guys, what can we do to make sure that this doesn't happen? And maybe it doesn't happen 90% of the time because we can't be perfect. So it was at the same time, so it's my own like minute counting, but at the same time, listening to speakers that are on the other side, like Regina Blevins is a really amazing mentor for me. So she's got many locations, and you'd think that how can she do this? She's spread thin. She's got associates and all of that she's bundling into it. But every time I listened to her speak, she was increasing the interval between appointments just a little bit. So I would come back to work and say, well, instead of 10 weeks between office visits, let's try 12. Let's try 16 and use virtual care. And what can we do to kind of experiment with what someone else is doing, but it doesn't always work. It doesn't, every practice is so unique, and things that work great in someone's workflow, you try to implement it and you just have to watch and be prepared to remove it again. Right. And so much of it's the team because I can bring in a new idea. And if the team isn't on board with changing their behaviors, then that's going to crumble too.
Is your home incredibly efficiently run? Like is dinner every night at 6:08 p.m. and ends at 6:22 or what? Like is that your life or just your practice?
It's funny that you say that because yes, dinner is typically at 5:35 and I'm done eating it at 5:40. But you know what? In all of this, when people see me running around, I do have two children. There is another person in my life that's helping me kind of keep this, right? So my husband is such a big part of this success, right? Because it's a partnership. He is going to be the one making dinner, making sure that I'm fed so I can clock back in and do some more clean checks and then clock out by 7:30 and watch a movie on the couch. So, yeah, everything in life has to be a little bit
That's awesome. I
minute.
love
That's
that.
Yeah.
amazing.
Excellent.
Michelle over there is very similar to that. So Michelle, I see a bright future for you.
You are light years ahead.
That's great. I wish I could adhere to that plan as much as you do. So you are incredibly efficient. You're able to see as many patients as you want in the time that you have. How do you get all these patients? How are you bringing them into your door? Were there times where you were like, there's not enough. I'm too efficient. I have a whole full day doing nothing because I've been getting too fast at this. How do you keep that going?
No, there's many parts to that. So, like first, when we decided to switch practice management systems to Greyfinch, and Greyfinch has this integration with Invisalign practice apps. So the new patient photos automatically go into the practice management software. The iTero scan automatically goes in. I had all these employees that were dedicated to administrative time importing pictures and making sure that like every time we took a scan that someone took those images and put them into the practice management system. So that created tension because suddenly these people didn't know what to do with themselves and they were arguing about whose job it was to take out the trash or mop the floor because the orthodontic jobs changed.
Mm-hmm.
And so same thing in practice where you might look at a whole day and as long as the new patient column's full, I shouldn't care about what's happening in the other columns. They're coming. They're being taken care of. Like they've paid. It's all about that new patient column. But to be frank, the last 3 months have been hard. Where are the patients? Because the dentists are still referring. I'm 50% based on dentist referrals. And that's from building relationships with like reverse referrals and Smile Architect and all those things we can talk about. But those basic 8 to 14-year-olds are on pause right now, these last few months. So yes, the column is full, but everyone's 59, 73, missing teeth, implants, intrude molars. It's not the easy stuff. It's not.
Maybe talk about that a little bit more
Yeah.
and your focus on branding and
Yeah.
marketing and what techniques you found are successful.
And it took a while of course it takes a while to groom or not, maybe not groom, but just like cultivate a culture in your area. So I'm grateful that in my area, Invisalign in my demographic is seen as high tech, exclusive, hygienic, good for young students. And so that patient population I found in 2023 was still steadily growing, but the decline in my practice was from adults. And when I looked at the demographics, we were not really seeing 20 to 40-year-olds. They were probably going somewhere else or choosing not to spend their money. So probably around 2023, I really started to hone in on, hey, I'm an expert in Invisalign. All of my D-bond reports say treated with Invisalign. So the dentist knows they're looking at before and afters. They're seeing great outcomes. How can I build up these partnerships with the dentists to get the more complex cases? Because that demographic age 50 and up typically has their finances in order that they can afford to do payment in full with a check. So let me target that audience. So it started slowly with Smile Architect, and I would see a patient consultation. I would post the clean check. I would do a little Smile Architect workup, and I'd send a message to the dentist saying, hey, what do you think? You know, I know they were sent over for orthodontics, but do you think they'd be a candidate for restorative for tooth wear at the end? And of course the dentists love that. Whether they say yes or no, they had a choice. And so that I built on that, and I built a really great relationship with a local prosthodontist that now sends me cases that are varying complexity. She knows what to expect. I'm going to create a Smile Architect simulation for this patient so they know how the restorative is going to pair with the orthodontics. And so that building those consistent referrals has really helped with the other side of the practice, getting those adults back in and the ones that can afford comprehensive treatment, not just like limited, you know?
Totally. That's really clever because I think that patients I mean, I even had a patient today who was like, are my teeth going to look like yours after? And she had really, which is obviously a good, right, a red flag, but also a compliment. But yeah, I was like, I mean, like she definitely had a Bolton. Now that just means she has like smaller teeth on top. And so I was like, I mean, we can just straighten it. If there's anything you want shape wise, like that's got to go. So I think by showing the patient My point is
Huh?
they don't know what they need. So it's not even like a manipulation tactic. It's like, this could be it. You could stop here and we can just straighten your teeth, or we can, shoot for the stars.
So much easier now because before I would have to submit an entire clean check. Now it's on the iTero. But I'm totally with you. The adult needs to see what does perfect look like? Because when they call and they say, I want it to look perfect, okay, let's talk about that.
Right.
And then they realize, no, you're right. I don't want perfect. And it's so cool the innovations that are coming out, 3D face scan, all these different technologies to show like a 3D image of a patient's face and then their teeth in it, and they can see their can't. It's right there. That was not something I created. It's been there. If you want to fix that, that's going to require something else. So it's just taking away the stress of
Yeah.
those patients at the end of treatment that don't want to go away.
Definitely. And we're speaking a different language. Like even today, I told a patient, their midlines are off, and they were like, what are midlines? And to us, that feels so obvious. But when you get to really show someone what that discrepancy looks like, I think that can make a massive difference. I do want to get a little bit into how you became a consultant for Invisalign. Did they approach you after you lectured for them? What does your kind of arrangement look like? Is that more of a side hustle? Like how much are you involved with that?
Mhm. So it started with, so I was already teaching for the university for the residents, and Align was creating an entire program that was, I think, like the care event that you went to, right? I think
Yeah.
that's where we met. It was a
Yeah.
workshop for residents. And so they were starting to build this. They were creating a university program where you could have events for residents and just trying to build that out. And so my chairman or past chairman, Dr. Boyd, actually recommended me. Said, hey, you should talk to Marta. She's doing like a couple local study groups and she's teaching for us. Give her a chance. It was trial by fire because I showed up to one of those events and I remember those residents were mean. They're like, where is your superimposition? Right? Because it's such a, when it comes to the residencies, they have so many different perspectives on what clear aligner treatment can do. And, they didn't want to come in and be sold. And so I was just trying to get my bearings. Like, these people don't know me and I'm just trying to do my best here.
Yeah. I'm new. I'm just a human.
Luckily it seems like over the years the residents have softened because they see the potential of what it can do, and now they're like, yes, I need to learn this, because that's what's going to happen in private practice. But it starts out as speaking engagements. So one-off consultant speaking engagements. And then eventually through application process or whatever, they have you become Align faculty. So you can be a speaker for Align, independent consultant, or then you can become one of their faculty, as they call it, which means we go get together for additional events for learning and things like that. So as I do it more and more, of course, my approach becomes more refined, my ability to speak in front of crowds, putting information together in different packages, I really enjoy it. And my favorite thing is when they say, hey, Marta, we want you to come to this event. We want this topic. And I don't have it yet. I don't have it prepared. So I get to go and make a whole slide deck because in creating that slide deck, I'm digging deeper into that particular malocclusion or question that they have. And so I just opened up a whole aspect of my practice. For example, like when I did Invisalign first for the first time, I went back and I looked at how much I was charging for phase one. How many office visits was I doing for phase one before I started doing Invisalign first? And I realized, oh my gosh, I'm seeing these braces kids 20 times. 20 times for like a 15-month treatment, and I'm charging $3,000. And you have this epiphany that this is not sustainable. And how can we flip that if we're doing Invisalign first? We have less office visits. Maybe we charge more for phase one than phase two, or, those kinds of things. So for me, it's really a passion project because I'm just uncovering layers of things that I'm doing wrong. I didn't even know I was doing wrong.
Right, right.
One-
It forces
one-
you to check yourself.
One question that I have had about the interaction of the orthodontists and Invisalign is, does it create a competition between the orthodontist and the general dentist? Or explain to us like where you see the domain of the orthodontist being preserved because of technical capability that general dentists don't have, or what other considerations
Yeah.
apply?
That's a great comment. So in the end, um, on this whole journey, I was teaching pre-doc dental students as well at the residency level. That was going on for a while, just some little bit to get them to be familiarized with what's possible in orthodontics. Here is a surgery case, not how. Here is an extraction case, not how. But it's so that the student who's going to become a dentist doesn't think, oh, Invisalign can't do XYZ, go to this orthodontist. I'll do your Invisalign treatment, but this looks hard. You need braces, go there. And that's, oh my gosh, that's the biggest frustration, having a patient in a chair that thinks that it can't be done. And so I welcome the dentist to see what's possible, but also really understanding kind of where is their own limit. Because fundamentally, when I see cases come through that general dentists have had a hard time with, the missing piece is the diagnosis. And that's what the orthodontist learns. It's like, okay, yes, this is a movie of teeth moving, and if there's bone, teeth can go there. But a lot of times the dentist doesn't have full understanding of where the bone is. Even with the CBCT integration, this envelope of tooth movement that we learn and this experience of, okay, at class 2, what are my limitations? How much distalization do I think is clinically possible? Because the clinchic will show you whatever you want it to do. So the reality is the dentists they've been doing orthodontics since the beginning. Dentists have been doing orthodontics. Even before Invisalign, dentists were sectioning study models and moving teeth on plaster models and making suck downs. Like they were doing this right along with us. It's just that Invisalign took it digital. And so where I see that distinction is really going to be us needing to learn the complex cases. That's where it's at. And that's what we're working through right now. We've got a collapsed extraction space. We need to open space for an implant, periodontally compromised patients, all of these like more complex cases and young growing patients. But that population in between who's 20 or 30 that needs a retreatment, they're not coming into me. As much as I advertise for them to come in, they're doing what's convenient, which is to go to the dentist, right? So when I have my partnerships, I have 50% referrals from dentists. Those dentists are still doing Invisalign. They're still doing it in their practices. And sometimes they ask for help, which is fine. I would rather help them than have them transfer the case to me, which is a whole nother can of worms. But once they try it a few times, they realize, okay, this is not easy.
I feel like a lot of what I've heard from, other experts like yourself is that they take on a lot of cases, and then once they're in it, that's when they start to regret that they did. So the first step is easy. The second step is where they start to question themselves. Where do you see the future of orthodontics in the next 10 years or so? What can we expect just based on I know you can't predict the future, but what you as an expert kind of foresee for us?
So using, of course, AI in diagnostics. Having AI there to come and say, have you considered this? Have you noticed this asymmetry of the nose? Have you done da-da-da? And now I need to translate all of that diagnostic information to what the patient's real chief concern is and get a really quality relationship and understanding with the patient and then find a solution for them. So if I could already have AI point out all of the little supernumerary teeth and things that I might miss on a CBCT or an efficient consult, and having it kind of point out those things to me. Or if I have, we've already got Invisalign personalized plan, which is not AI, but it is my own personal plan of what I think I would do 80% of the time, getting that even better on top of integrating what we know from CBCT information. So I would love to know what happens when a tooth moves. Does it move through bone or with bone? Okay, so that's something in orthodontics we still don't know. And then I would love to have a better force system that is based off of that person's natural anatomy, like their bone density and their roots. So that's like on the clinical side, on the diagnostic side, all these pieces coming together is going to help me be more efficient and get a better plan that's more customized for that patient.
That's awesome. Yeah, that's really, really cool. And then I want to know, like, what do you wake up at 4 a.m.? I'm a little worried that you do, and that's what I have to do to be like you.
Hey, if you've got to make it to the gym. No, it's more like 4:45. Yeah.
Oh my God. Are you
That's
tired?
why I have an Aura ring now because I've got to make sure I get at least 7.5 hours.
Oh my God, good for you. Wow. And then, so do you go to the gym before work and then,
Yeah.
okay. All
Oh,
right,
yeah.
good for you. All right. I aspire for that. I'm like a 9 hours a night kind of girl, so I need to figure that out. All right. Any last questions from you guys?
You spoke a lot about how you've kind of integrated a lot more of these increasingly difficult and challenging cases, especially in older patient population. So, how do you manage a lot of those patient expectations, especially when we get to kind of the end of treatment? We've done a lot of those big movements, and they might be nitpicking something very small that may or may not even look the same to you
Yeah.
as well.
So I learned early on that every complex case, they have restorative planned. There's going to be some restorative, or there's a really strong restorative dentist behind it. And what, it's great to build a relationship where you get as far as you can go, and then, okay, time to go see the prosthodontist. And the prosthodontist sees and says, "This is amazing. We're ready to go." Because there's so much that they can do with restorative that we can't do, limitations of bone and tooth shape. So that's one aspect, making sure that there's a clear cut. So most of these complex cases are only 6 to 12 months because I'm just trying to get them to restorative and they don't want to be in treatment for more than 12 months. No 73-year-old signed up for 2 years of orthodontics. They just want the incisors proclined a little bit to make space. But what you're talking about is the patients with unreasonable expectations. And so, of course, that's still going to happen because that sometimes is not, sometimes you can't rationalize with a person, and you know that happens where you'll never please that person. But for the most part, having a software that you can show them this is where we're heading and this is why, and having CBCT integration really took away a lot of that nitpicking as you describe, because it's very easy for them to see a fenestration. You're asking for buccal root torque on the canines because you don't like how they're flared out. Well, if we do that, your teeth are going out of bone, so on and so forth. So the more that these tools for showing them, if I do what you're asking, this is what will happen, that's really decreased some of those miscommunications.
Do you take a CBCT on every patient?
Yeah, so the Plan Mecca Visio ultra low dose setting is 11 microsieverts, which is the same dosage as my old Plan Mecca Pano, digital Pano. And I
Uh,
used to do a Pano and Ceph, which is more radiation than in my ultra low dose full volume. And the information that I have is at least is there's probably bone where I think there isn't bone, so it makes things look worse, which makes me more conservative. Okay.
okay.
But I would not want to treat an adult without a CBCT. When I realized how many times they have buccal root torque on the lower incisors, or mesial root tip on the lower canines, and all these little root movements that, are going to compromise the perio or the final result. So, yes, CBCT for everyone.
I'm just panicking over here. We do not have a CBCT, but noted for when I have my name on the building. Dad, any last
Yeah, so
questions?
so a another technical question based on my years of orthodontic study. I read, I think it was in the New York Times or Wall Street Journal recently, an article that said that preteens and teens are going back to hard metal braces because they like the look, which is blows my mind because growing up, like I never had braces, which you could probably all tell looking at me, but the kids who had them, it was like 2 years of misery for them. They hated it. They couldn't wait to get them off. Are you seeing that trend that kids are like think that it's cool to have hardware in their mouths and is that something that's playing out?
So it's not playing out in the Bay Area where I'm at because it's very high tech area. They see virtual care, they see less office visits. The most of my patients are first generation, so some of those influences that we might be seeing in other demographics. But it's interesting to see the generation that wants everyone to know that they're on a journey and they want that journey on their face. I'm going through something. And so like that those themes keep when I see my own kids, those themes keep on like they want to show that they're experiencing something. So I don't know where that's going to take us with clear plastic that you aren't supposed to see that someone's on a journey, but It's tough. There are definitely some markets where the influencers have gotten in, and braces are what's seen as the higher value item. So I don't know
So
what
new product idea for Invisalign is decorator Invisalign, not clear,
They got that.
but
They got
but
that,
like
Dad.
but a rainbow. I'm
yeah.
just throwing
So
that out there. I mean,
should they make it different colors?
yeah,
Should they add fangs to make them look like canine, vampire?
cartoon characters, SpongeBob across the bottom, those.
Right. Have
But
your name on it.
Right,
it's
exactly.
like they just got to get those focus groups of the 12 to 13-year-olds and get
By the
in.
way, Kylie's going to edit me out of this entire program.
No, I love he's a lawyer. I don't know if I told you that in the beginning, so he doesn't know anything about what we're saying.
Nothing.
All these ideas are probably like, secretly patented and
Right. Now I'm thinking about it.
It's
Things are
it's an
moving.
IP trap I'm setting. Yeah.
Yeah. Okay. I wish I could talk to you for so much longer, but I do really want to get to some cases.
Yeah, the most common questions I hear about from orthodontists are extraction cases or dumping, which personally I feel like unless you're really feeling super confident with your Invisalign skills as a whole, we probably shouldn't be stepping into extraction cases until we're able to kind of do other types of cases, but cleaning up those molar dumpings. And then distalization is a really common question people ask, like, can I distalize? How much can I distalize? I heard you can't even distalize. So I pulled up a case where I have the very first ClinCheck that the Align gave me, and then I have the one that I approved, and then I'll show you how it turned out. So right here in the initial setup, we have a patient who is full cusp class 2, but her upper midline needs to shift over. It's a totally different story if the upper midline is on and the lower midline is off. That's a lot more difficult because now we're talking about a skeletal asymmetry in the lower jaw. But this one's pretty straightforward because you can run class 2 elastics, correct the class 2, and shift the upper midline to be coincident with the face. And so you can just kind of see the comparison of some of the decisions that I made in just attachment selection from what they gave me when it first came through. So one, patient is class 2 on this side, so I want to sequentially distalize on an adult, but she needs to have her third molars out. So there's the movement as it goes, root control attachments on all of these teeth, class 2 elastic for anchorage, and I felt like I should add an attachment onto the canine, which also is going to ultimately be distalizing a little bit. So I added a conventional there, but everything else is pretty much what I got from Align, since I had root control attachments on premolars, and then these multi-plane attachments, which are for like rotation. So then I look at the final tooth position on both of these, and you can see that the very first one, there were limits to how much the software was going to correct that crossbite. So the crossbite was still there at the end. So I just went in and I tipped the tooth to get it back into the arch form. So that's where it finished on their side. And then I added a little bit more tip lingually to get the tooth out of crossbite. Let's look at the other side. And the modification in attachments was when we're doing buccal root torque on a molar, there's no optimized attachment for that. And so I put a horizontal beveled occlusal to get some control there. And then since I don't need class 2 elastics on this side just yet, since I have a unilateral class 2, I decided to hold off on elastics on the left side. So, and then on that lower molar that I'm doing some movement on, I put another attachment. And then overall though, the staging, you can see 59 stages versus 63 stages. The staging is pretty much the same as what was the default, except I said it was okay to start aligning the teeth from the front, like in the front to start with. So that's the difference in Invisalign. You can have sequential distalization, which means each tooth moves halfway back before the next tooth starts, and then halfway back before the next tooth starts. And typically in that version of sequential distalization, they don't move the front teeth. But most of our patients, you can start aligning the front teeth without getting a lot of like round tripping where you tip them out too far or those kinds of things. So for this case, I wanted them to start aligning the front teeth right away. For a teenager, I would do it differently. I would do their improved sequential distalization because this is a 24-year-old. Improved sequential distalization would be less aligners, and every 3 stages the next tooth moves. So they don't wait until the tooth gets halfway back. They just start moving every 3 stages, which works really well for young growing patients. The other thing I did was I took away the interproximal reduction on the left side. That's not really something that I needed right now. I was trying to shift her midline over to the right. So I removed that. And then finally, there's no optimized attachment for like rotations on centrals. I probably could have gotten away with some root control attachments, but I just at the time decided to use some conventional. So we can take a look, which is what I do every time that I get an additional aligner. I open up what I'm working on and I compare it to the last one that I approved. So here's the one. Let me close this out. Let me get back to where I was. I will go open this one. Number 5 is what I'm going to work on, and I'm going to compare it to what I approved. And this is where my learning happens. These are my aha moments because I look at this patient and how well at stage 0 she looks compared to where she started. And then I look at what I planned against what I got. And that's where I realized I didn't do any over-treatment on this case, except for a little bit of extra intrusion. That's pretty much it. I only did a little bit of extra intrusion, maybe not even that, but pretty much she tracked completely without any meaning over-treatment, meaning if I need torque, I add 5 degrees more. If I need expansion, I add 0.5 millimeter more, all of that. When it comes to complex cases, the more that we over-treat means we're adding more force to the system, which isn't necessarily a good way to move teeth. Teeth move with light pressure. So in the primary order, when I have a lot of things going on, I don't really build a lot of over-treatment. And so now I can look at how this tooth distalized, because obviously it went really well. So what did I do right? And if you really dial into what this molar is doing, most of the movement on this molar, because you know how we have the 3 types of movement. We have tipping, uncontrolled, tipping, controlled, and root movement. Or torque, maybe there's, more to it. But all of the movements on this molar are tipping movements. You could have done this with one finger. And if you can look at it at all angles and realize that that's a difficult movement, but I could do it with one finger, meaning pressing on one surface of that tooth, then it's a very predictable movement as long as your patient wears their elastics, right? So that's really how it was. But I see a lot of people trying to distalize at the same time, because right now you can see the crowns are tipping distally here, or the teeth are translating a little bit. I see a lot of people building in distal root tip when they're trying to distalize, and that's just building in anchorage to resist the class 2 correction. So if you're planning distalization on an adult, it should really be either bodily or a little bit of distal crown tip as you're correcting this. And then you can always, in the additional aligner, go in and start detailing marginal ridges and all of that stuff. So when I assess a case and I come at it for the first time, I say, what's the most important thing for me to fix in this first round so that it tracks? And then in my second round, I'll detail marginal ridges and some aesthetic stuff. So for this patient, it was distalization, arch form, making sure the bite was opened, and now all I have is a little bit of spacing and some detailing to settle the bite. The other thing I notice is when I run unilateral class 2 elastics, thinking about your orthodontic studies, when you are doing class 2 elastics and you imagine like an arch wire and you're pulling on the arch wire where the canine is and you're pulling distally, the other side bows out. So I do find that when I run class 2 elastics, I get excess buccal overjet on the other side. Do I do anything in my primary order to fix that? No, because sometimes I get that excess buccal overjet and sometimes I don't, because there's cheek pressure, there's tongue pressure, there's other factors at play. So I would just go in and tuck these teeth in on the next round. So we can do distalization so long as we have space in the maxilla, we have good tipping movements, and we're not building in anchorage by putting roots first into those movements, and then finally compliance, cooperation, patients doing what we ask them to do. That's like probably number 1 for requirement to get these cases to go. So are there any questions on this one before I show an extraction case?
So actually, Michelle had this question, but just I feel like while we're here, so it sounds like sequential distalization is your preference if it's possible.
For an adult that's not growing person, where I'm trying to correct and the midline is either off or they're crowded on that side, sequential distalization works really well. If you have a mandibular asymmetry, you've got a different problem. So sequential distalization is going to move the upper midline off of the facial midline. When it comes to a teenager, they're growing at the same time. Things move a lot easier. I only do improved sequential distalization on teens when I'm trying to decrowd for the canine and I don't want a round trip. So if this were a teenager and I just started to align things and then run class 2 elastics for en masse, I would have a little bit of a harder time with that crossbite tooth, I think. Because I would be en masse trying to distalize at the same time that I'm trying to constrict that tooth. So the reason for the success too is that there's a buccal crossbite and we're doing it sequentially. That was another aspect to it. So if you've got a teenager with anterior crowding, you're trying to distalize the teeth and you don't want to procline the upper incisors and create overjet, distalization is really good for that. But for the most part, if I have a basic class 2 with large overjet, I'm not doing distalization. I'm just doing basic elastics because they're growing, their lower jaw's coming forward too.
Got it. Got it. That makes
And are you
sense.
usually doing your typical 7-day wear switching schedule, even for distalization in adults?
So for me, it's about getting the right combination of amount of time in aligners. And for this patient, 63 stages, I felt confident that I could do this in a year. Like this, I could get somewhere where I was ready to get to the next part. I felt like this would track with this 1 year cycle. But sometimes you get a case and it's 15 stages. You took all of the effort of bonding all of these attachments. Are you really going to see them 4 months later and take all the attachments off and order another aligner order? Because in the end, the software is, they're basing the number of stages based off of linear movements of 6 points on the teeth. And one of those points is the root apex, but it's not the true root apex. It's their constructed apex based off of GV Black from like dental school.
Mhm.
Meaning that if you have super long roots, you've got to do 2 weeks per aligner because the amount of time for that root to move is longer. So for the most part, if I have 20 to 30 stages, I'm happy on a teenager to do 7 days for that because I'm ready. They're growing, they're doing elastics. In 6 to 9 months, I'm ready to scan for the next set. More teeth have grown in, second molars, blah, blah, blah. For an adult, if there's only 20 aligners, I'll probably ask them to do 10 days so that I can get at least 200 days out of that before I do the whole refresh, since biology is a little bit different too. So there's a lot that goes into the days per aligner. I don't want to artificially increase the number of stages because if you have one example where it's 20 stages and you just decide to double it, well, each of the stages was designed to move the tooth a maximum of 1/4 millimeter. If you just double the number of aligners, that means the maximum movement an aligner can do is 0.125. So you effectively decrease the force per aligner, which isn't what we want in orthodontics. We want gentle pressure over time, but not so gentle that we don't move the teeth. So I don't increase the number of stages to match 7 days, like just by saying double, but I do play around with staging. So if I have only 15 aligners, I might say rotate first and then extrude, just to do something to increase the number of aligners without just telling them to double it, you know?
Do you
Makes sense.
normally set it up like that, especially in terms of the staging? Because I know a lot of patients look in the mirror and you can tell them, oh, it's going to go back one at a time, but they're really concerned about how those front teeth look. So would you say you commonly set it up to kind of align the front teeth and then work on the bigger movements?
There's a double-edged sword to that. So I found during the pandemic, I was doing sequential distalization on a teenager that was wearing her aligners but not her elastics. And I have seen people who showed me their sequential distalization cases and they say it's not working. And what you see is that the front teeth are totally flared out because without the anchorage of the elastic, your upper incisors are proclining. And so all of this, what you're describing, is patient psychology. This particular patient, I was confident. She's young, she's paying for it herself, she's wanted to do this her whole life, and she extracted her wisdom teeth for me. Those are all factors that are putting together a super cooperative patient. But if you have your regular 14-year-old and you say that we're going to move one tooth at a time and you're going to wear your rubber bands, If they're not mature enough to understand the bigger picture of where they're heading, you're going to end up with side effects that you didn't want. So actually, most teenagers, I don't assume that they're going to wear their elastics. So I just align the teeth and see what I can get with elastics in the first order and then do like a side by side. So I find myself doing a lot less distalization in teens because they can't necessarily use their frontal lobe to understand the long game. You're working on abstract ideas like bite. And so the teens drop off on the second aligner order, and then you realize, oh, you didn't wear your liners. Now we have to do one more, and then they wear their third. And so to avoid that vicious cycle, you could consider not straightening the front teeth. That's a totally reasonable manipulation where you keep the teeth crooked and then they understand that but generally I just go off of mechanics. What's going to be easier for me with mechanics? And sometimes I don't want to align the front teeth because I don't have space until I distalize. But sitting down with a teenager and saying, this is what we're doing. And then at the end of that aligner order, I do a side by side where I show them where they are and where they started. And if I don't see a difference, then they clearly know that they weren't wearing them and I call them out on that. And if I do see a difference, I say, this is amazing. You must be so proud of yourself. But if you don't wear this next set, your teeth are going to go back exactly to here. And it's a little bit of just education for the patient so that they know where they're at to help them stay engaged, you know?
Smart. Yeah. They need to feel like they're a part of it or they're not going to want to keep wearing them.
Yeah, that they're part of the journey.
Yes, exactly. So while you're pulling that up, I just want to remind you of something that you said when we first were learning from you. It may have been Dr. Sandra, but I think it was you. I think the optimized attachments had I don't know if they just came out or you guys were kind of trying to promote them just because a lot of doctors were always changing the optimized attachments. And so I was like, okay, if we're keeping all the attachments and, a lot of the movements are correct that are in Invisalign, like what are you mostly spending time with on your clin checks besides if it's an active sequential distillation or something like that? And you said removing unnecessary movements.
Yes.
And that stuck with me so hard. So do you find yourself still just in general, if you're distalizing a tooth, if we don't need to be rotating something, why are we adding extra forces?
Well, it's interesting that a lot of people, when I was doing a workshop with some orthodontists the other day, they were saying, what do you do with severely rotated premolars? I remove the mesial distal angulation. Trying to rotate a tooth at the same time that you're adding 10 degrees of lingual root torque and 10 degrees of mesial root tip, that's not going to track. And in the end, I realized during my residency that we had to look at every CBCT and turn it into an anatomage model. And we had to set up all of our cases. So it's basically doing a CBCT clin check back in 2011. And I realized how many patients the apex was actually in the right spot. It was the crowns. And so if you think about that, so you flip your CBCT model upside down, your apices are in the right place. You really just need to kind of tip the teeth into the right spot in the primary order. And then if you need marginal ridges and root parallelism, you can do that in the next order. Well, if they could use our CBCT, and then now in IPP, you can actually set root apex limits, but it's still the constructed root. That's the future. Go in there and say on class 2 patients, I don't want to see the apex of the lower teeth moving mesially. And on class 2 patients on the upper arch, I don't want to see the apices moving distally, right? Just mesially on the lower, you don't want teeth tipping mesially because Andrew's 6 keys is actually where the crowns are tipped a little bit towards the front. So there's so many things in final tooth position that we'll be able to customize once we can put more rules to it of things that we believe, the apex shouldn't move on this premolar, just spin the tooth. That's going to track really beautifully. So I still spend a lot of time removing unnecessary movements or simplifying the movements if I have a bigger picture problem. So if someone has a situation where they have a buccal crossbite on a premolar, upper spacing and overjet, and a deep bite, I don't want to do everything in the first order. In the first order, I'm actually going to fix the crossbite on the upper arch, and I'm going to fix the deep bite. And then later I'll retract the incisors because I don't want to retract into the lower incisors when I'm doing that. So in the end, it's also looking at where are teeth going to collide that prevent the teeth from moving or bigger anchorage. So there's a lot to it. It's even if with my IPP, there's so much still brain work where we're learning. And then at the same time, I might do a clin check and Dr. Ty might do a clin check, and they're similar, but they're different enough that you could never copy us, Yeah, it's not a cookie cutter solution when it
No, it
comes,
really isn't. Thank God, because
yeah,
we would be out
right,
of a job.
right. So for extraction cases, just real quick, here's a situation where I needed to do lower fives because she had a missing premolar on one side. And then just the crowding pattern, we decided to do upper fours, lower fives. And so in my first order, I've got vertical attachments on the lower on one side, and I've got optimized attachments on the other side. But what you're really looking at is the posterior teeth don't move. And that's one of the fundamental things that I think is going to take us to the next level for extraction cases. If you are bringing the posterior teeth forward at the same time that you're bringing the anterior teeth back, you're effectively closing the space faster. But if you treatment plan the back teeth not to move and you bring the front towards the back, now you just reduce the rate of space closure. And it's not that the back teeth aren't going to move forward. If you look at their superimposition, this is not magic. It's not a tad. They're still going to get mesialization, but the actual plastic shape is designed where the front teeth are moving towards the back. And so this is how she turned out at the end of that first series. So the bite's a little bit open, and I didn't run class 2 elastics because they can pull the aligner off or create other side effects. So if I can get away without elastics on the first round while I close the extractions, I'm happy with that because I can run elastics in the next order. And so that's where she ended up. And so I did an additional aligner where I'm adjusting marginal ridges, I'm doing different root control movements, and I'm running class 2 elastics to finish this case up. She came back at the end of this round, and didn't I tell you that a patient that had a dramatic change in their first order, they don't necessarily wear the second order as well? Well, she wore it well, but then she fell off a little bit. So this is where she was at the end of that 26 stages, but the lower incisors had some relapse. So we did one more round of aligners, and then this is where she ended up. So it's not impossible to do. It's just about making sure that the staging is right, because I've played around with leapfrog. And leapfrog is where first you move the premolars, then you move the posterior segments, then the premolars, posterior, like this is what it looks like. And it's a lot of aligners. And I was dabbling with this, trying to see if this was going to be a good solution for me. And in the end, so this would be leapfrog, whether it's better than the Invisalign staging, I don't think so. I think it just makes more plastic. But the system is still the same, where the posterior teeth are kind of staying where they're at and the anterior teeth are retracting. And with virtual care, which is absolutely required for my extractions cases, everything's going great. And then you look at the twin, who is everything about her is almost the same. They're not identical twins, but they both needed the same extraction pattern. And here I am doing leapfrog, and I've got my attachments, max anchorage, and all of the things same way that I had on the other one. And then at 69, she's not tracking. Teeth are dumped into the extraction space. And you look at virtual care, and it was just a compliance problem. And now to clean that up, to clean up that issue, or to upright a molar, we can't expect to upright it and mesialize it at the same time, because that's an extreme moment. That's like segmental appliances with a major tip back in it. So in order to upright a tooth, you actually have to upright it first, and then you can resume space closure. That's just how the mechanics are going to work out for you. There's no way you can put enough of a moment to continue space closure at the same time as uprighting, which means this young lady now is faced with a sentence of 79 aligners to upright. And I don't know where she's at now, honestly. I have to go check her virtual care, but I have to watch her closely on virtual care now, because if she doesn't upright, then she can't go back into space closure. And that cost her time. So the alternative in this situation would have been to put fixed appliances on. She's a high school senior. She wants to continue with Invisalign. I said, that's fine. This is what happened because you dropped off on wearing them. Now you're faced with a longer treatment time because we have to clean up the molar tipping before we can get back to space closure. So that's like my 2 cents on extractions. Any questions on extractions?
Amazing. I mean, I think that I have so many questions, but I'm like, you know what? Everyone needs to go check out Dr. Baird on the Invisalign courses. Everyone has access.
This might be a good time to mention. So, like, even my extraction tips, Dr. Sam Lee is a little bit of self-promotion. Dr. Sam Lee and I noticed this gap where we would be on stage and we would have all these beautiful cases, and then people are like, wait, but more. I need more. And so we created this website, this business called Smart to Ortho Solutions. It's a combination of our names. And we've published our first base course, which is all of our practice workflows and everything we do to be digital. Since I'm 90% Invisalign and him as well in his Invisalign side of his practice, since he has a partner. But like, this is where we're trying to dump all of our knowledge. And I think that anybody who signs up for this list, there's going to be email blasts with like free content as well as tips and things like that. But that's what I've been working on for the last since June, since we decided, hey, we're going to make this happen. And we got that published. I'm really excited, and AGD, PACE certified, and all that stuff.
Amazing. Amazing. Okay. I know we're nearing the end. I mean, I can't thank you enough. This was amazing. Like I said, I wish we had another hour, but I know you have the minutes. You probably have dinner waiting for you. But maybe we'll do this again at some point. Maybe like when we get more advanced with it, we can ask more sophisticated questions. I'm going to sign up for your newsletter. Michelle, anything final?
This was fantastic. Thank you so much. You know, Kylie and I went to residency together, and there's a lot of things that as a resident they do and don't let you do because they have our professors have their knowledge and expertise too. So a lot of it is also just trial and error and seeing so many cases, and the possibility of what we can do with aligners is really incredible. And thank you for showing us those cases today, and for
My
your
pleasure.
time. You're very inspirational.
Seriously, I'm like, I need to like go. I'm gonna wake up early and start like reading a textbook tomorrow morning because this is, I'm inspired. All right, go enjoy time with your family. Thank you so, so much.
Great. You guys have a good night then.
Yeah, you too. Thanks so
Thanks,
much.
Dr. Baird.
Bye.
Bye. Thanks for listening to Medical Morons. Don't forget to subscribe, rate, and review.